So we are. So now I invite Dr. Himangini Shah to present the biodata for Dr. Deepti Shastri.
Thank you, sir. Thank you for making me part of this prestigious Dr. Rita Sood Memorial Oration. It is a special feeling, sir, because it is because of my mentor, Rita ma'am, that I was hooked onto medical education, as it was she who encouraged me to apply for the FAMER Fellowship in 2007 at the NCHP at AIMS, Delhi. And the very next year, in 2008, I was doing it. She also holds a special place in my heart because she's my son's teacher, Omkar, who has been doing his MBBS at AIMS Delhi, and she was teaching him medicine at that point of time. So it's my gratitude to you, sir, for giving me this proud privilege and honor to introduce yet another person very close to my heart right from my MBBS days at Goa. Ma'am, that is Dr. Deepti Shastri, a name that resonates with academic administrative excellence and that surely can do justice to this oration. Armed with this MS Anatomy degree from Goa Medical College in 1993, she flew from her comfort zone the very next day of her result to join Father Muller Homeopathic Medical College, Mangalore, as a very enthusiastic and confident assistant professor. She joined the Vinayaka Mission's Kirupananda Variyar Medical College in 1998 and has moved the ranks as professor and even headed the department and has had a dedicated, distinguished service that encompasses various accomplishments that has a reflection of her academic as well as administrative acumen and passion, a few of which are Dean of Faculty Medicine, Vinayak Mission Research Foundation, the Deputy Dean, VMKV Medical College and Hospitals, Chairman UG and PG Board of Studies, Member Board of Studies for Preclinical at Goa, former member Postgraduate Board of Studies, Kerala University of Health, the member of the executive as well as the Academic Council VMRF, with her ECME in 2014, she has also been a convener in curriculum committee and the MEU coordinator as well. She has made anatomy very interesting to students, undergraduate and postgraduate alike, through her 27 years of experience not only at her institute but has spread her knowledge far and wide through the Swayam Prabha portal, been a reviewer DTH NPTEL for medical recording, has conducted live workshops, CME webinars, and today, very aptly, this oration. The research pool at large has been enriched with her expertise as section editor for embryology in the Journal of Anatomical Society of India and editor in chief National Journal of Basic Medical Sciences, and of course, her very own 50 publications in national and international journals. Pardon me, ma'am, for keeping your accomplishments in brief, but I would like to mention a little more about her. She has been ably guided in her journey earlier by her mother, an elegant lady, a woman of steel herself, and later very well encouraged and supported by Dr. Rahul Mukherjee, her husband, a general surgeon who was also my teacher, who has enamored her and has been enamored by her ever since 1991. Talent flows in the family as her son Tanmay Mukherjee is pursuing his PhD in biomedical engineering at the Texas A&M University. So, ladies and gentlemen, senior faculty members, my colleagues, presenting to you the very elegant woman of substance, Ma'am Dr. Deepti Shastri.
Thank you so much for that generous introduction, Dr. Hemangini. You mentioned my mother. That was really very touching. I lost her on 25th of September, so it was extra special that you mentioned her name today. Thank you, Dr. Hemangini.
Thank you, ma'am.
Sir, can I share my slides?
Yes, you can. You will have to unmute yourself. Yes.
Thank you, sir. Na gurur adhikam tattvam, na gurur adhikam tapaha, tattvam gnana param nasti, tasmai shri guruve namaha. There is no greater principle than the Guru. There is no greater penance than the Guru. There is no greater knowledge than meditation on such a Guru. My salutations to such a Guru. Respected Dr. Sanjay Bedi sir, Dr. Tejinder Singh sir, esteemed medical educators, and my dear friends, good evening. I feel extremely privileged to have been invited to deliver this oration, Dr. Rita Sood Memorial Oration, this month. Never in my wildest of dreams did I imagine that such an honor would be bestowed on me by stalwarts in medical education. I do hope I do justice to the responsibility. Unlike Dr. Hemangini, I had unfortunately not had the opportunity to interact with Dr. Rita Sood. But I had my own fangirl moment in 2009 when Dr. Payal Bansal and Dr. Rita Sood visited SRMC in Chennai for a panel discussion on faculty development programs. I feel deeply humbled to be delivering an oration in the memory of one of the finest medical educationists India has produced. It happens to be Dr. Rita Sood's birth anniversary month. Her birth anniversary being on 21st of October. And it feels extra special to be presenting this particular oration on this day, 25th of October 2025. I would like to express my sincere gratitude to Dr. Sanjay Bedi sir and Dr. Tejinder Singh sir for this honor. Well, dear medical educators, we gather as professionals who have dedicated our lives not only to treating the sick, but for shaping the next generation of healers. And in this sacred task, curriculum is our most powerful instrument. Allow me to begin with a rhetoric question. When was the last time that we paused to reflect not on the diseases that our students must diagnose, but on the system that diagnoses them? The curriculum itself, if poorly designed, can become a pathology. It can suffocate creativity, drain compassion, and even lead to anxiety and stress in students as well as faculty. But if it is designed wisely, it can heal, it can inspire, and it can transform. And as quoted by Nelson Mandela, education is the most powerful weapon which you can use to change the world. And that is why today I wish to speak on three simple yet powerful ideas: blueprints, burnouts, and breakthroughs, and how these can guide us in designing resilient curricula for contemporary Indian medical education. Let me take you through the landscape of medical education in India briefly after the introduction of graduate medical education regulations in 2019. We noticed that CBME 2019 was revised and updated in 2022, 2023, and 2024. Competencies are at the seat of CBME, competencies for knowledge, skills, attitudes, and communication. We also saw elements being introduced into medical education like foundation course, self-directed learning, early clinical exposure, integration, ADCOM, student-centered learning, learning doctor method of training, sports and extracurricular activities, electives, and clinical skills lab, amongst many others. Some of the CBME milestones have been the 2022 revision adapted curriculum to new timeline required by the pandemic while retaining the core principles of the CBME approach. There was introduction of family adoption program, making at least 3 families to be adopted as mandatory, but preferably 5. AdCom questions were introduced into any university exams, but initially they were very vague. Which AdCom module had to be assessed in a particular subject of a phase was not specified. There was a revised exam schedule where forensic medicine was shifted from 2nd MBBS to 3rd MBBS Part 1. There were academic adjustments like electives, which were scheduled to be of 2 months duration, was reduced to 1 month and divided into 2 15-day blocks. There was promotion of yoga, 1-hour daily yoga sessions for 10 days, leading to the International Yoga Day on 21st of June. There was recommendation of Charak Shapat to be administered to medical students when they begin their training. The pandemic module and online learning and assessment were introduced following the COVID pandemic. And there were talks of the national exit exam. The foundation course of 1 month duration was revised to 1 week at the beginning and the remaining hours spread over 6 months. And the timeline of professional years were made to have many changes. The first MBBS period was reduced from 14 months to 12 months. Second MBBS remained at 12 months. Third MBBS Part 1 saw a roller coaster ride. It was reduced from 13 months to 9.5 months, 10.5 months, and now seems to be settled at 12 months. The third MBBS Part 2 was increased from 13 months to 18 months, and there was yo-yoing of ophthalmology and ENT. Initially, it was these 2 subjects were added to third MBBS Part 2, but in 2024, they have reverted back to third MBBS Part 1. The Indian medical graduate roles were defined in 2019. There were 5 of them earlier: clinician, communicator, leader and member of a healthcare team, lifelong learner and professional. And it was expanded to 7 roles by addition of critical thinker and researcher. Continuous internal assessment marks were specified as 500 in theory and practical each in the year 2023. Passing criteria was reduced to a minimum of 40% separately in theory and practicals and 50% combined. No grace marks are to be allotted to students. MSc PhD faculty were made ineligible as examiners. And supplementary exams saw a sea change from 6 months before CBME was introduced to 90 days after the regular exam results in 2019 to within 3 to 6 weeks of the regular exam results in recent times. The major revisions that were introduced in 2024 were some of the certifiable competencies were altered. The foundation course was reduced from the initial 175 hours in 2019 to 80 hours. Remedial options were provided for students with low attendance below 75% in theory and 80% in practicals, but above 60%. They have remedial options to make them eligible for taking up university exams. In line with the National Education Policy 2020, students now have the option to be assessed in English and 12 other languages. Outcome competencies, which were very vague initially for assessment, have been earmarked for each subject with 1 SAQ each in each paper. Early clinical exposure hours have been reduced from 30 to 27. Mentorship program has been recommended, which needs to be longitudinal, where a single mentor would be in care of his mentee from first MBBS to final MBBS. And finally, blueprint of question paper has been recommended in 2024. The blueprint, in addition to having scenario-based MCQs, long essay questions which are either case-based or structured, and short notes, we saw the advent of two new type of questions. One is reasoning questions and applied anatomy, any subject, applied aspects, um, specially related to 6 integration modules. The 6 integration modules being anemia, hypertension, diabetes, ischemic heart disease, thyroid, and tuberculosis. Now, the students need to focus not only on competencies like history taking, clinical examination, attitude, communication, professionalism, but we also emphasize on early clinical exposure, integration across various disciplines, logbook entries, formative assessment, and so on. So, what is the result? The students are overloaded. What about the faculty? The faculty are overburdened with endless logbook monitoring, feedback following formative examinations, remedial classes for poor performers, which results in delayed exam paper corrections, and the constant stress of compliance with the ever changing guidelines of the CBME curriculum, necessitating a change in timetables and teaching schedules every year. So the faculty are drowning in paperwork. The medical education unit members, along with the curriculum committee, curricular subcommittee, topic team, ADCOM committee, electives committee, in short, the entire institution is working laboriously to keep up with the NMC upload deadlines. So institutions are compliance driven. So what is the result? The result is a paradox. While the curriculum looks modern and student centric on paper, in practice, it can feel exhausting, both for the teacher and for the student. This is the paradox. And that is why resilience must be the keystone of curricular design. And the first pillar of resilience is the blueprint. A blueprint in education is not just a table of specifications. It is, in fact, a map that aligns objectives with teaching learning activities and teaching learning activities to assessment methods. And it ensures that what we value most in our students is actually what we evaluate. So, the oft repeated cliche, assessment drives learning, now has a corollary, but blueprints drive assessment. Why do blueprints matter in a country like ours? Because we deal with a vast student cohort, uneven resources, diverse universities. We have government, private, deemed universities, each with their own curricular framework. And without a blueprint, assessments may risk becoming capricious with low content and construct validity of assessment tools, with either overemphasis or underrepresentation of certain content. The assessment may be unfair, it may be biased, and have a poor alignment with competencies, which result in anxiety and stress in students. A well designed blueprint, however, can address this. It ensures fair coverage, prevents bias, and indicates to students what you're being asked in an exam is exactly what you were prepared for. But blueprint comes with its own challenges. Faculty time is stretched. Internal assessments take days together for consolidation because each answer of each student has to be corrected manually. And there is variation across departments. There are different formats, different weightages, and different expectations. Any problem comes with its own solution. So, what are the blueprint solutions? Digital platforms for blueprinting, faculty training in blueprinting, uniform assignment formats. So, digital platforms for blueprinting can generate blueprint aligned question paper in minutes. This is a sample of what we have developed in our university, where the various kinds of questions, whether they are case based or structured, MCQs, short notes, long essay, short answer questions, have been mapped to competencies. They have been mapped to the different domains of learning and the different domains, the different levels of the cognitive domain and different difficulty levels. Faculty development programs. Faculty training in blueprinting can empower teachers to see blueprinting not as an administrative burden, but as a professional safeguard for themselves and for their students. I am honored to have Dr. Nirmala Rege ma'am attending this session. We had Dr. Nirmala Rege conduct a focused workshop on blueprinting in the year 2020 after the curriculum committee members were sensitized on blueprinting during ACME. And I was fortunate to have Dr. Tejinder Singh sir guide me during blueprinting during my ACME program in 2014 at CMC Vellore. Of course, now BCME itself has introduced blueprinting as one of the topics on day 2 of the workshop. Uniform assignment formats. Institutions can adopt uniform assignment formats to reduce duplication of effort. Uniformity of these assignment formats can be monitored by a committee that can be set up for the purpose. In short, blueprints are the curriculum's immune system. They ensure that there is alignment between objectives, teaching learning methods, and assessment, which might ultimately lead to better outcomes. And of course, they protect the curriculum from randomness and ensure that there is integrity. The second pillar that we need to confront is burnout. And this is a topic that is not taught in medical colleges. Of course, stress management finds a place in the foundation course. But is a 1 hour session in the first MBBS sufficient to prevent burnouts throughout the MBBS program? Should there be a look at a longitudinal program to contain burnouts? Burnout is not just a psychological buzzword. It is a syndrome which causes emotional exhaustion, depersonalization, resulting in disengagement, reduced sense of accomplishment, leading to cynicism. And it is rampant in all medical colleges, affecting both faculty and students. We must remember that we cannot heal our patients if we break our students. We did a comparative study in our institution to assess the job stress levels among faculty members in medical institutions. And the findings indicated that the stress levels are so common in medical faculty that it has become a part of their lives. We concluded with our study that efforts must be made to hire adequate, well-trained, and effective faculty, discuss their grievances, and take appropriate actions to alleviate stress and anxiety. Who can forget those famous or infamous words of Mr. Narayan Murthy, who said, youngsters should work 70 hours a week, which was followed by the controversial comments of the head honcho of L&T, Mr. S.N. Subramaniam, who said, how long can you stare at your wife? How long can wives stare at their husbands? Get to the office and start working. In fact, he said, get to the office and start working on Sundays. Mr. Anand Mahendru, the chairman of the Mahindra group. He fortunately offered respite by his rebuttal. My wife is wonderful, love staring at her. That said, administrators must recognize the importance of the personal lives of the faculty, and at times they would be prioritizing it over office work. Effective coping strategies need to be adopted by the administrators, including stress management techniques, periodical retreats, engaging counselors, medical experts, or psychologists to provide support and establish a stress free working environment. How do burnouts in students and faculty manifest? What are the warning signs? Among students, we see it in the form of disengagement, rote driven learning, poor attendance, and a loss of empathy. And among faculty, it manifests as workload fatigue, delayed task completion, loss of joy, irritability, and that sinking feeling of just checking boxes instead of inspiring young minds. So the outcome is a burnt out teacher cannot mentor effectively, and a burnt out student may become a disengaged doctor. So are burnouts inevitable? Certainly not. Resilience can be built. So, what are the protective factors against burnouts? Early alerts for poor progress for students so that interventions can happen early before failure and not after. Mentorship and peer support programs should be encouraged in institutions. As far as faculty are concerned, faculty wellness programs and technology should be introduced for repetitive tasks so that the faculty receive a well supported environment. The National Task Force on Mental Health and Well-being of Students recommended a system within the institution. Faculty wellness programs including dedicated time in yoga, or maybe even chair yoga can be introduced for faculty. Also, mindfulness sessions also help or benefit the faculty immensely. What we also need to build on is our adversity quotient. So, what is adversity quotient? It is a measure of a person's resilience and ability to cope with and overcome adversity and challenges. This term was coined by Paul Stolz, and it is considered to be a predictor of success in life alongside IQ and EQ. The core competencies of AQ are control, ownership, reach, and endurance. Control of one's own emotions and stressful situation, and not becoming helpless when faced with challenges. Ownership is willingness to take responsibility for one's own action and responses instead of blaming external factors. Reach is how far the impact of adversity will spread to other areas of life and performance. And endurance is perception of how long the adversity will last and maintaining persistence throughout. These core components form the foundation of resilience and effective coping in medical education and healthcare settings. So, what is the impact of adversity quotient? As I mentioned earlier, it is a predictor of success in life. Individuals with high AQ are more likely to succeed and thrive in challenging situations because they view setbacks as opportunities for growth, not as failures. Workplace performance, a high AQ will lead to better job performance, effective stress management, and the individual will positively contribute to the growth of the organization. Academic achievement, students with a high AQ will be able to handle academic pressures and setbacks more effectively, which will result in improved performance and well being. Personal development AQ can be improved by developing skills like growth mindset, problem solving, perseverance, and emotional intelligence. So, how can we improve one's AQ? One is by normalizing struggle through discussions, mentorship, and regular feedback that consider challenges as growth opportunities and not as failures. By embedding resilience training, which include stress management, mindfulness, and coping techniques, which can all be incorporated into ADCOM and life skill development sessions. We need to promote a supportive culture by open communication, peer assisted learning, and an important factor, zero shame environments with errors or difficult clinical situations must be developed in our institutions. And all these can be achieved by using task based challenges like simulation exercises, case based scenarios, flipped classrooms in order to build adaptability and confidence. We need to recognize and reward perseverance, academic and clinical achievements, not just outcomes, by reinforcing effort, grit, and ethical persistence, is how we can recognize and reward perseverance. We need to provide access to wellness resources like counseling, mentorship programs, burnout prevention programs in order to enhance emotional and mental stamina. The third pillar is breakthroughs. This includes innovations and reforms that make resilience possible. And the breakthroughs can be structural, cultural, which results in compassion, and technological. So, what are the structural breakthroughs? Uniform assignment formats, which I mentioned earlier, across departments, which reduces duplication of effort. Introducing digital dashboards for tracking internal assessment, attendance, and CBME progress, all in real time. Implementing OSCE and OSPE that test skills in a fair and standardized manner. These would be structural breakthroughs. Some of these breakthroughs are cultural. Cultural breakthroughs would embed reflective writing after maybe cadaver dissection and clinical postings, recognizing and celebrating compassionate acts by faculty and students, and mentorship networks where no student feels invisible. Technological breakthroughs are AI enabled blueprint linked question banks, which generate blueprint aligned question papers in minutes. Early warning analytics that flag struggling students. Virtual simulation labs that can that's where the students can practice safely before patient encounters. The beauty of these breakthroughs is that many of them do not add more to the curriculum. In fact, they remove redundancy, they streamline effort, and they create space for meaningful learning. As the saying goes, resilience is not about enduring more, it is about needing less. The resilient curriculum triangle of blueprints, burnout, and breakthroughs need to be balanced. When blueprints, burnout prevention, and breakthroughs are in harmony, learning becomes healing. Institutional workflow for resilient curriculum must not only include objectives, teaching, assessment, and outcomes, it should now include wellness. So, what is the strategic way ahead? The faculty must be role models of balance and empathy. Students must develop higher adversity quotient. Institutions must invest in digital technology and wellness programs. And policymakers should encourage flexibility and innovation. These are my references. My reflective wrap up is: to the teachers, the wish should be to teach wisely, to nurture gently, and to inspire always. And musings to students: the best doctors are not just those who pass exams, but those who sustain compassion over a lifetime. Thank you for joining me in this journey. May our blueprints be strong, our burnouts be rare, and our breakthroughs made many. Thank you once again.
Thank you, Dr. Deepti. I mean, it was a very emotional and deep thought-filled talk. Thank you very much. And we are proud to present to you the Rita Sood Memorial Oration. Once again, thanking you for this, accepting this session, this oration. And with this, we end this session. In fact, the number of participants exceeded 100, and they were all there on on YouTube, on which the lecture will be available. Thank you very much. With this, we end today's session.
Thank you, sir. I'm deeply honored by your invitation and permitting me to present this oration. Thank you so much, sir.
Thank you.